Drugs for type 1 and type 2 diabetes mellitus. This presentation covers slides 17 to 35 of your slide set. This information presented in this course is based on reference materials that are believed reliable and consistent with standards accepted at the time of presentation. Possibility of human error and ongoing research and development in medical sciences does not allow assurance that the information contained herein is in every respect accurate or complete. The information presented during the course is intended for teaching of undergraduate and graduate students in biomedical education and is intended only for teaching. Students who successfully complete this course should check the product information sheet included in the package of any drug they plan to administer or dispense to be certain that the information presented in this course is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. July 9th, 2014. This slide depicts for us the insulin receptor-mediated signaling that occurs in target tissues such as fat cells or skeletal muscle cells and in liver to some degree. If we look at the very top of this slide, you can see insulin receptor. It's a receptor tyrosine kinase, insulin having bound to it and activating it, causing the phosphorylation of the IRS1. Now, if you look at this IRS1 diagram here towards the middle of the slide, you can see that its activation by the insulin receptor causes something called membrane trafficking. Do you see that there at the bottom portion of the center of this slide? The bottom center, membrane trafficking. And mitogenesis is another issue that we've discussed, but the membrane trafficking is an important aspect here because within the cells of the target tissues there are glucose transporters. So if you follow that arrow that leaves membrane trafficking and you now follow that to where it goes in this diagram, you'll see something called GLUT4. And what that diagram is a picture of glucose transporter 4, which is sequestered here within vesicles. And upon insulin stimulation and IRS1 and its signaling cascade, those GLUT4 transporters translocate from the cytoplasm to the surface of the target cell. In so doing, glucose can now enter into the target tissue. And so we can look at glucose transporter 4 or GLUT4 as a high throughput glucose transporter, allowing excess sugar out of the blood into target tissues. And so it really is that insulin receptor interaction that's controlling the insertion of the transporters into the cell membrane, allowing glucose to enter into the target cell. Now, yes, if you look at other arrows coming off of IRS1, you see activation of something called the MAP kinase pathway, which is involved in cell growth and mitogenesis. And you also see effects on glycogen synthesis and lipid synthesis, and those effects in particular being stimulated by insulin. So storage of glucose as glycogen, storage of fatty acids as triglycerides. Okay, so this slide nicely depicts the signal transduction pathway of insulin in target tissues, such as skeletal muscle, for example, or adipose, for example. This slide depicts the terminology associated with all of the abbreviations on the previous slide. I'm not here to ask you to know all of these abbreviations, but if you're curious and you would like to look at the previous slide in the context of what all those abbreviations mean, you have that here. For example, MAPK excuse me, stands for mitogen activated protein kinase, or PI3K stands for phosphatidylinositol 3 kinase, or IRS1 stands for insulin receptor substrate. But again, I'm not here to have you memorize what all the terminology is, but if you're curious and you'd like to know the names to the abbreviations, this slide provides that for you. And I apologize, there's a few typos on here, which I'll need to fix. This slide presents us with an interesting observation concerning insulin on its own release. Insulin actually has a positive autocrine feedback loop on its own secretion in the presence of glucose. So what does that mean, an autocrine feedback loop? Well, autocrine means that a cell that secretes something, that something affects the cell that secreted it. Right? Auto means self. So a cell releases something, that something affects the cell that released it. And so, for example, insulin is going to be released by which cell? You remember? In the islet? Very good. The beta cell. And so much of that insulin is going to go into the blood and going to be taken to target tissues. But some of it will bind the receptors on the surface of the beta cell itself. And so the secreted insulin binds to the insulin receptor on the plasma membrane of the beta cell, which initiates a cascade that involves the insulin receptor substrate proteins. And when that insulin receptor substrate is active, one of its targets is something called SERCA3, and SERCA stands for the sarcoendoplasmic reticulum calcium ATPase. And here we're not dealing with cardiac cells or muscle cells. We're dealing with beta cells of the pancreas. But SERCA, when it gets phosphorylated in the pancreatic beta cell, becomes inactive and unable to bring calcium back into the endoplasmic reticulum. And therefore, the calcium levels floating around in the cytoplasm remain high, which promotes the fusion of vesicles containing insulin to the cell membrane and the release of insulin, as you can see here towards the center middle of the picture. So tyrosine phosphorylation of IRS1 leads to the inhibited activity of SERCA. More calcium stays out there in the cytoplasm, which increases insulin secretion. Now, again, I don't mean to dwell on this for at length, but insulin has been found to have a positive autocrine feedback loop, and what that basically means is that a little bit of it that gets released can actually bind to the beta cell and cause more to be released. And we'll discuss the mechanism of release in more detail in a moment. Now again, we're looking at insulin receptor on a target tissue. Could be a muscle cell, could be a fat cell, but here we're in the context of a skeletal muscle cell. Insulin binds to its receptor, IRS protein gets phosphorylated and affects downstream mediators. If we look, IRS protein has several targets. Among them, targets that are involved in the activation of protein synthesis, in glycogen synthesis, and in the transport of GLUT4 transporters to the cell membrane. So as you look at this slide, there's a green box around some of these targets. And this is what we think of insulin when we think of it as efficacious for diabetes. Glucose coming into the target cell, being converted to glycogen and stored. However, if we look to the left, we also see that the activated insulin receptor phosphorylates a substrate called SHC, which further activates proteins that are involved in mitogenesis or cell growth and division. So insulin is actually, in addition to its ability to lower blood glucose, is a growth factor. And so we should keep that in mind when we think of this idea of insulin resistance, of patients who are insulin resistant and oftentimes hyperinsulinemic, meaning levels of insulin much higher than normal, but yet their body isn't really utilizing insulin to its best potential for clearance of glucose, but may be utilizing the insulin for growth of certain cells. And the cells I have in mind here are tumorigenic cells. So again, we discussed this in class a little bit about this insulin hypothesis, hyperinsulinemia, obesity, and increased risk of cancer. It's by far not a resolved issue, but seems to have some points that are worthy of further research. Again, not all obese people get cancer, but obesity is a risk factor, increases a person's risk of cancer. So anyway, I'm kind of going off the point here. The major point I'm trying to accentuate is the fact that really the right side of this, that glucose transporters get inserted into the cell membrane, that more glucose gets cleared out of the blood, that proteins get synthesized from amino acids, that glycogen gets made from the glucose that has come into the cell. Or if we're in the fat cell, that triglycerides are synthesized from fatty acids that have come into the cell. One last thing I'd like to mention in terms of pharmacodynamic effects of insulin is that glucocorticoids have been found to lower the affinity of insulin receptors for insulin and antagonize the effects of insulin, while growth hormone increases the affinity of insulin for its receptor. And in fact, insulin helps growth hormone achieve its effects, particularly during growth spurts, for example, during puberty. So growth hormone increases the affinity of insulin for its receptor. Glucocorticoids lower the affinity of insulin for its receptor. And that's depicted for you here in the upper portion of our slide. Continuing on the discussion here of GLUT4 transporters and insulin, this diagram shows you a summary of other factors that can increase GLUT4 translocation to the target cell surface. We've talked about insulin and its ability to stimulate the translocation of the glucose transporter 4 to the surface of the cell and allow glucose uptake to occur to a higher degree to clear more sugar out of the blood. Again, one may pause at this moment and say, why do you even need a glucose transporter? And if you think back to some of your basic biochemistry, you realize that glucose is highly hydrophilic and on its own would not be able to cross the cell membrane. It's too large and it's too polar. And so cells have devised ways of getting glucose into them, and there are multiple glucose transporters, and we'll get into that in a moment. But the GLUT4 is what we call the high throughput glucose transporter. And so insulin obviously will increase membrane trafficking of this transporter to the surface, allowing more GLUT4 transporters on the surface, allowing more sugar to enter target cells. But there are other factors that can increase GLUT4 translocation. If you look to the right of this diagram, you see that exercise has been found to stimulate translocation of glucose to the cell surface of target cells, as well as hypoxia. Now, more of a focus on exercise because we know that exercise is beneficial in diabetic patients. It helps with reducing their average blood glucose levels over time in patients who are able to regularly exercise. And so we've studied mostly the left portion where the green arrow is and insulin's ability to do that. But if a patient can make a lifestyle modification, if, for example, they're sedentary and they are not very active, and maybe they're obese, and now they've got type 2 diabetes, exercise in some cases can be very helpful in reducing their disease state. Now, you don't want to overdo it. Moderate exercise has been found to be effective, and you'll hear more about that, I'm sure, in the clinical portion. So again, when we think of insulin and diabetes, we think of it as the ability to clear glucose out of the blood / storage molecule. It promotes glucose uptake into cells. The cells will use some of it to make ATP and will store the rest of it as glycogen. And so we see increased glycogen synthesis. We see that insulin decreases glycogenolysis and gluconeogenesis, which makes sense if you're stimulating uptake into the cell out of the blood of glucose, and you're stimulating storage. Then why would you want to break down what you just stored, and why would you want to put more sugar in the blood? It doesn't make sense. So insulin actually promotes uptake, increases glycogen synthesis, but decreases glycogenolysis and gluconeogenesis. It also stimulates lipogenesis, right? So fat cells get bigger. We see fatty acids being stored as triglycerides. We have the inhibition of lipolysis, with one exception. Lipoprotein lipase is actually activated, but lipases within the cell are inhibited. So overall, we see an inhibition of lipolysis. We see fatty acid synthesis, triglyceride esterification, and the inhibition of ketogenesis, less ketone bodies. Remember, one of the complications of severe insulin deficiency in patients untreated is diabetic ketoacidosis. Insulin reverses that. If we look at insulin at the very top of this slide, we can kind of characterize it in two ways. We can call it anti-catabolic or pro-anabolic, which in some ways are two synonymous terms. But let's look to the left. Catabolic effect would be taking glycogen and breaking it down to glucose, or taking proteins and releasing the individual amino acids, or taking triglycerides and breaking them down into their individual free fatty acids. That would be catabolic effect, breaking down, catalysis. Well, anabolic effect would be taking that glucose molecule and storing it, making polymer out of it, storing it as glycogen, or taking the amino acids and stringing them together as a protein, or taking those free fatty acids and esterifying them to glycerol to make triglycerides. If we look at these processes, insulin has the anabolic action, the building, the storing. But cortisol and other corticosteroids or glucocorticoids have catabolic effects, right? They're great for their anti-inflammatory actions, but they also have catabolic effects, causing glucose levels to rise in the plasma, causing protein degradation or breakdown into amino acids, and causing increased free fatty acids in the blood out of triglycerides. So if we look at this, in the red box, cortisol is really a physiological antagonist to insulin. They're not competitive antagonists. They're not working at the same receptors and all, right? Cortisol has its own receptors. Insulin has its own receptors. But these would be physiologic antagonists. And so insulin is going to stimulate glucose and amino acid uptake. It's going to increase utilization of glucose. Amino acids and free fatty acids are going to be converted into storage forms. ATP will be made from some of that glucose. And in the context of these metabolic events, we should also realize that thyroid hormone levels play a role. Thyroid hormone is intricately involved in overall cellular metabolism, and it's been known for many years that if thyroid hormone levels are altered, we can have altered effects on these storage molecules. And in fact, low levels of thyroid hormone decrease the effect of insulin. High levels of thyroid hormone will increase the effects of insulin. Hopefully your patients are having normal levels of thyroid hormone because they're being treated with either T4 if they're hypo, or they're being treated with some kind of anti-thyroid drugs if they're hyperthyroid. But that green box below is just meant to show you that in the context of metabolism, we have to remember that thyroid hormone plays a role. And thyroid will be a topic of a future lecture. So we'll discuss this again. Now this slide summarizes really everything I've mentioned, adds a little bit of additional information. And so here we've got type 2 diabetes. So we got a patient, this isn't the normal situation. We've got a patient that's got too much glucose in their blood, hyperglycemia. And so they've absorbed some sugar out of a meal. And if you look at the very top of this slide, you'll see the intestine. Glucose has been absorbed through the intestine. And normally that glucose would be cleared and enter into target cells and would be useful for storage. But here we've got type 2 diabetic. If we look now at the bottom of the slide, we see the pancreas is releasing insulin, but the diminished effects of insulin on target tissues are occurring because of insulin resistance. And so, rather than storing fatty acids, for example, the fat cells are releasing fatty acids into the blood. If you look to the right of this slide, right, rather than esterifying them to glycerol, the glycerol is coming out of the fat cells. So rather than having stored form of fat, fatty acids and glycerol are being released into the blood, and they're traveling to the liver. And in the liver, these molecules serve as precursors for gluconeogenesis. And so fatty acids are being converted into acetyl-CoA, ketone bodies are being formed. We mentioned that there are 3 types of ketone bodies. 2 of them are acidic, and one of them is acetone, which is volatile. Okay, but ketone bodies can form. Again, in the type 2 diabetic, we don't usually worry about diabetic ketoacidosis because there is some insulin action. If there was no insulin action, then these ketone bodies would accumulate to very high levels. But nonetheless, if we head back down here to the liver and we look at the gluconeogenic precursors, well, now we see that in this type 2 diabetic that's already got high levels of glucose in the blood, that's already got poor insulin sensitivity, gluconeogenesis is kicking in, and the patient's liver is actually making glucose and dumping it into the plasma. And it's either making it through gluconeogenesis directly or through glycogenolysis because of diminished effects of insulin. And this causes complications. We see chylomicrons accumulating, we see LDL accumulating, we see increased risk for atherosclerosis in the diabetic. We mentioned in last lecture about vascular complications of poorly controlled diabetes. So again, this is the diagram showing you the interaction between the fatty acids, between the ketone bodies, and gluconeogenesis. In this picture, we still have some insulin function. In the type 1 diabetic, those ketone bodies can definitely accumulate and acidify the blood, and so the type 1 diabetic will need to be given back insulin for those reasons. Okay, back to insulin secretion. Such an important hormone. We know now, after our discussing this for a little while, that insulin is released from the beta cells. And it's not that there's no insulin ever, right? We have what we call basal levels of insulin. And then we have insulin that gets released at higher than basal levels when the beta cells are stimulated to release it. By far, the most common signal for insulin release is glucose, but there are other stimulants that also cause the beta cells to release insulin, and among them are other sugars, certain amino acids, and even vagal activity. And so exactly how is the insulin released? Well, if you look at this rectangular structure here in the bottom of the slide, this would depict a pancreatic beta cell, cartoon sketch. And if you look to the leftmost portion, you'll see a glucose transporter there, a round blue circle. That's letting glucose just come in. That glucose transporter allows glucose to come in. It's not GLUT4. It's a constitutive glucose transporter. What that means is it's always there. It doesn't have to be stimulated to be in the membrane. But remember what we said about GLUT4? GLUT4 is a high throughput glucose transporter in target tissues. This glucose transporter is low throughput. It lets some glucose in. The glucose comes in and it starts to get metabolized, and ATP is produced. Well, these cells have a potassium channel which is going to be open or closed depending on ATP levels within the cell. It's called an ATP-gated potassium channel. So when the ATP levels within these beta cells is high, that channel closes, causing a depolarization. The depolarization results in a calcium channel opening. Calcium floods into that beta cell, and granules of insulin are going to then move to the cell membrane, fuse with the cell membrane, and participate in exocytosis, allowing insulin to be released into the blood. This is a very important model of how we believe the beta cells release insulin, because there are certain drugs that target this ATP-gated potassium channel. Among them are sulfonylureas and meglitinides, which target the channel slightly differently, but same target, where they block the channel, depolarize the channel, allow that calcium channel to now open, and allow those insulin-containing granules to be released. So definitely try to have this mechanism comfortably under your belt before we start to talk about the oral hypoglycemics, such as the sulfonylureas, because that will really help you understand the mechanism of action of those drugs. So again, the glucose transporter lets the glucose come in. The ATP levels go up because that glucose is metabolized. As those ATP levels go up, the ATP-gated potassium channel closes. That causes a depolarization of a calcium channel, voltage-gated channel. It allows calcium to rush in, and we see the release of insulin into the blood. This is an electron micrograph actually showing you the exocytosis of insulin from a beta cell. If you look at this slide, you actually can see the extracellular space into which the insulin is being released. You can actually see the insulin is dark, on this slide, black, staining crystalline substance. And you can actually see it fusing with the cell membrane and releasing insulin into the extracellular space. Okay, so this is just meant to show you in a real beta cell how the insulin is released. So we know insulin gets released. We know insulin is a hormone that is carried by the blood to target tissues. Well, the next question is, how is insulin degraded? And really there's two major areas that are going to remove insulin from the circulation: the liver and the kidney. And the enzyme that does this, that degrades insulin, is a glutathione insulin transhydrogenase that's given a common name, easier to follow, insulinase. ACE meaning enzyme that cleaves what? Cleaves insulin. So we have insulinase in liver and kidney. Once that insulinase hydrolyzes the disulfide bonds, there's a further degradation by proteolysis. The liver normally clears the blood of about 60% of the insulin that's released from the pancreas. The kidney removes the rest. Now, in patients receiving exogenous insulin, it's been observed that there's a reversal of this, that more of the insulin is removed by the kidney, and by the liver when you give exogenous insulin. And really the value of knowing that is that you're going to want to make sure that your patient's kidney function is optimized. We've already talked a little bit about how the kidney is definitely a target for hyperglycemia. Poorly controlled hyperglycemia, glomeruli can be destroyed. So anyway, getting back to things, insulin doesn't have a very long half-life per se. It's rapidly degraded by an enzyme insulinase and further by proteolysis. And the two primary sites of exit are the liver and the kidney. The half-life of circulating insulin is 3 to 5 minutes. And so you might very shortly be asking yourself, well, if I have such a short half-life, how can I have long-acting insulins? How can I have long-acting insulins that basically try to mimic basal insulin levels in the body? Well, the answer to that really has to do with absorption. And we're going to discuss more of that as we get into the insulins and the different pharmacokinetic parameters relating to insulin, such as rapid acting versus long acting versus intermediate acting. I'm going to get into that more in class during lecture. Just to give you a point of reference, basal insulin values are about 5 to 15 microunits per milliliter in healthy people, and they go up to about 60 to 90 microunits per milliliter during meals. And so this is really kind of the extremes. 5 to 15 as basal, 60 to 90 as postprandial. And so that's what the body does. And so when you give back insulin, you're trying to mimic what the body does. Now, in somebody with hyperinsulinemia, these values can be much higher. And oftentimes those people are going to be insulin resistant to some degree. But again, I'm digressing a little bit here. So this is just, I'm not asking you to memorize this, but you have something called basal levels of insulin, and you have the peak levels that you can achieve after meals. The effects of insulin on its targets. Again, if we look at the pancreas here in the middle of the slide, we can stimulate it to release insulin by things like the vagus stimulation or by increased blood glucose. And that insulin gets released into the blood and has actions on liver, fat, and muscle. It promotes the storage of fat as well as glucose, which are actually both sources of energy. It promotes synthesis from circulating nutrients of those macromolecules, glycogen, triglyceride, and protein. And so basically we think of insulin in diabetes as having to work on these targets, having to work on the liver, on the adipose, and the muscle to allow a patient to have pharmacodynamic efficacy, that hyperglycemia can be restored to normal glycemia. In the liver, we see anti-catabolic action, right? We see inhibition of glycogenolysis, inhibition of the conversion of fatty acids and amino acids to keto acids, and we see inhibition of the conversion of amino acids to glucose through gluconeogenesis. Pro-anabolic effects, we see storage, glucose stored as glycogen. We see triglycerides being formed to store fatty acids, and very low density lipoproteins being formed as well. If we look at insulin's action on glycogen synthase or on glycogenolysis, basically what we see is that in the lab, this is a graph of an experiment done in the lab, that as you add glucose, the activity of phosphorylase diminishes, right, the green line. So shortly after adding glucose, there's no reason to liberate glucose from glycogen, right? I mean, you've just added glucose to the liver, exposed it to the liver. And so phosphorylase is blocked, and glycogen synthase activity is stimulated. Okay, so When you add the glucose that gets absorbed into the liver through GLUT4 is some of it's used for energy, and the rest of it is stored by glycogen synthase into glycogen. So in summary, blood glucose regulates liver glycogen metabolism. The infusion of glucose into the bloodstream leads to the inactivation of phosphorylase, followed by the activation of glycogen synthase. A summary of the metabolic effects of insulin in terms of excess or deficiency. We're going to focus on insulin deficiency. Insulin excess can occur in the presence of a certain tumor called an insulinoma, or in some cases, if the insulin dose is wrong and the patient gives himself too much insulin. But for the most part, insulin deficiency is the problem we're trying to correct in type 1 diabetes. And so in the deficient patient, ketogenesis from fatty acids is way up, gluconeogenesis from amino acids is way up, glycogenolysis is way up, and lipolysis is way up. And all of these are contributing to just the body making even more sugar, putting more sugar into the blood. And even though the body's hyperglycemic, it's somehow lost the ability to know that. And so it's dumping out more sugar through glycogenolysis and through gluconeogenesis. And so when we treat a patient with insulin, we are reversing these deficiencies and preventing these things from happening and helping the blood glucose get back to normal or as close to normal as it can. So a few things about glucose transport. We've already mentioned that you need a glucose transporter to let glucose into cells. And in fact, there are multiple glucose transporters, so we'll get to that in a moment. All cells in the body, except muscle and fat, possess unrestricted glucose transport systems. Fat and muscle cells need insulin in order for that GLUT4 transporter to be inserted into the cell membrane. So fat and muscle cells are highly dependent on GLUT4. The action of insulin in those targets is to recruit the glucose transporter 4 from the intracellular pool to the cell surface. But again, we can look at this as GLUT4 being the insulin-sensitive transporter. Sometimes I call it the high-throughput glucose transporter. While a GLUT transporter like GLUT1 found in all cells would be the basal transporter, low throughput, lets glucose in, but not to the same degree that GLUT4 does. So what do you mean? How can you have two different ones? Well, let's imagine that GLUT1 allows a certain amount of glucose in, that the doorway is 3 feet wide. So at any given time, you can only have 1 or 2 people coming in through the door. Let's imagine the GLUT4 transporter, rather than being 3 feet wide, is 300 feet wide. So at any given moment, you can have literally tens and hundreds of molecules entering. Not exactly that scale, but hopefully that illustrates the point. Okay, so GLUT4 is quantitatively the most important one in terms of lowering blood glucose. It gets inserted into the membrane of muscle and adipose cells from intracellular storage vesicles in response to insulin, and so we call insulin-sensitive glucose transporter. In the pancreatic beta cell, we have GLUT2 transporters, and it's been found that defects in GLUT2-mediated transport of glucose into those beta cells may contribute to reduced insulin secretion that we can see in certain types of type 2 diabetes. So I should say that not all people are type 2 because they're insulin resistant. Some of them are insulin deficient. They just don't make enough insulin. Okay, so that's an important point. Not everyone with type 2 is insulin resistant. Some are insulin deficient. How are you going to know? Well, you're going to have your blood work. You're going to know if the patient's not making enough insulin or if they're making too much. Glucose transporters, as we've mentioned already, are needed to allow that hydrophilic glucose to enter into the target cell. And these transporters come in different types. this table lists for you the different transporters that we know of, the tissues in which those transporters are found, as well as their functions and their Km values for glucose binding. As you can see, the GLUT1 transporter is found in all tissues, while the GLUT2 transporter is found in a few places, but we often think of it in terms of its importance in the beta cells of the pancreas. Remember, those transporters are the glucose sensors. How high are the blood glucose levels? The glucose comes in through the GLUT2 into the beta cell. The beta cell starts to make ATP. The ATP-gated potassium channel shuts. Calcium floods in through the calcium voltage-gated calcium channel, and insulin gets released, if you remember that diagram. So GLUT2 is a transporter found there in that pancreatic beta cell. GLUT3 is found in the brain, the kidney, placenta, a few other tissues. While GLUT4 is the insulin-sensitive glucose transporter exclusively found in skeletal muscle and adipose tissue. The GLUT5 transporter is interesting. It's found in a few places like the gut and the kidney, but it's interesting because it actually also allows the transport of fructose in addition to glucose. So it's the only one of the 5 that will allow the absorption of fructose as well. So I don't think it's necessary to know the tissue distribution of all of the glucose transporters or the substrate specificity of all of them. Obviously it's glucose or it's fructose on the substrate specificity, but it would be good to know that GLUT1 is the basal glucose transporter, that GLUT2 is found in the beta cells of the pancreas, is the glucose sensor. GLUT4 is the insulin-sensitive glucose transporter, and GLUT5 allows transport not only of glucose but of fructose. And so now that's going to bring us up to where I begin the lecture for Thursday, September 4th, where we start to talk about insulin as a pharmacologic agent, and we talk about the various pharmacokinetic preps of insulin, the rapid-acting, regular, and so on. From this point on in the slide set, you will have been lectured in class. And so I'll end the YouTube video here, and we'll resume on Thursday with insulin as a drug.